Welcome to Lifestyle Medicine Grand Rounds for May 20th, 2025, co-sponsored by Rochester Lifestyle Medicine Institute and the William J. Folletti Center for Lifestyle Medicine. And tonight our topic will be beans for the beans. We'd love it if you would consider partnering with Rochester Lifestyle Medicine Institute. We have a number of programs to help you empower your patients, Zoom-based facilitated programs that build motivation and competence in a socially supportive, interactive environment. And several of our programs are ACLM certified, including our very own 15-day whole food plant-based jumpstart and the Lift project. Both of those, by the way, will get you 10 credits if you go through it as a healthcare professional. This is just a little more detail, which I'm not going to read all about, but you'll see up here, you can see where you can get 10 CMEs for going through the Jumpstart or 10 CMEs for going through the Lift project. We also have health coaching for any of your patients who could benefit from that. We have a new program now, Jumpstart On Demand, which is the descendant of our Jumpstart Live program, which not everybody can get to because it does have 6 live Zoom meetings associated with it. But your health, your schedule, it's the same science, it's the same tools, and you get the same learning management system. And we are going to be introducing office hours in the near future, so there will also be a live component, but not quite as much as for the live program. And in terms of privacy, the presenting health professional has made every attempt to protect the privacy of the patient or patients being discussed. So our case presenter tonight, who will be doing the heavy lifting, is Dr. Paul Berkowitz. He's a nephrologist in Ypsilanti, Michigan, with 40 years of experience. He's a member of the William J. Folletti Center for Lifestyle Medicine, which is part of IHA Lifestyle Medicine, and he's also on the Committee on Disease Reversal. He graduated from State University at Buffalo, Jacobs School of Medicine and Biomedical Sciences, and completed his residency at New York University Medical Center. Dr. Berkowitz is board certified in both internal medicine and nephrology, and completed his nephrology fellowship at the Albert Einstein College of Medicine. Dr. Scott Liebman is our guest panelist. He's a professor of medicine at the U of R right here in Rochester, where he's been since 2004. He received his MD from the State University Health Center, Science Center in Syracuse, completed an internship and residency in internal medicine at Mount Sinai in New York City. A lot of New York City connections here. Nephrology fellowship in Colorado, and his public health, master's of public health in Rochester. His professional interests are in the fields of home dialysis, patient education, and lifestyle management of kidney disease. And he's the chair of ISPD's Education Committee and is also the medical director of the Freedom Center Home Dialysis Unit in Rochester. He's also previously served as the nephrology training program director at the University of Rochester, and he's board certified in lifestyle medicine as of 2018. Dr. Robert Brakey is one of our regular panelists. He's board certified in family medicine and lifestyle medicine. He's been a family physician in Ann Arbor for almost 40 years and serves as the medical director for the William J. Folletti Center for Lifestyle Medicine, as well as the chair of the governing board of IHA. And he's on the board of several national organizations. And I'm going to skip now to Dr. Graff, who's one of also our case manager. She's the one who kind of wrangles these cases. She's board certified in both family and lifestyle medicine and a graduate of the University of Pittsburgh School of Medicine, and has practiced in primary care settings for over 27 years in Western New York. And in the interest of time, I'm going to just leave that up there for a second, but people can read it on the video. And you can see there she is, the case coordinator. And then there's me. I'm the moderator tonight, also the president and founder of Rochester Lifestyle Medicine Institute. So also thank you for attending. We'd love it if you could support us. We are a nonprofit dependent on our donors. And so please consider making a generous donation. And now, without further ado, beans for the beans, and I will stop sharing, and Dr. Berkowitz's slides should magically appear. There they are. Perfect. All right, take it away, Dr. Berkowitz.
Okay, thank you very much to Rochester Lifestyle Medicine and the William J. Folletti Lifestyle Medicine Institute for inviting me to make this presentation. You know, as lifestyle practitioners, clearly one of our pillars is whole food plant-based eating. But the question arises whether that's advice we can extend to our patient population with chronic kidney disease. So that was the impetus of the talk, to understand the role of plant-based eating and whether it's safe, whether it's effective, and what other issues might arise. So let's get on to the case. And the case is of a 68-year-old male who first came to the office for evaluation of chronic kidney disease. However, before we can really get into the discussion of him as the patient, He was wondering if there was anything his family members or friends could do with respect to diet that might prevent them from developing chronic kidney disease and having ever have to meet a nephrologist. So I believe there's a poll question.
People could answer that as quickly as possible. Okay, Kim, let's see the results, please. Okay. Well, let's go to Dr. Brakey. Dr. Brakey, what are your thoughts about the response here?
Well, that's absolutely correct. As Dr. Berkowitz, I'm sure will outline for us, we've been colleagues here in Ann Arbor for quite some time. My dad was a urologist, and when it's absolutely correct, the majority of people pick there as conclusive evidence. It's reached a point of excellent evidence-based approach to managing chronic kidney disease, such that even the National Kidney Foundation is recommending plant-based diets for people. So I won't steal Paul's thunder, but that's what I picked, and majority were correct.
All right. Dr. Graff, your thoughts, please.
Well, that is absolutely true. But also, it doesn't matter. Even if there wasn't, there are also plenty of other good reasons, great reasons for going plant-based. So I wish this was one you could pick either or. And you could put both of those in there because there's lots of great reasons for eating plant-based. But there is data. So, and we're going to see it. So let's see it.
All right. Excellent. All right. Back to you, Dr. Berkowitz.
Okay. And yes, as mentioned, there is some data. Hopefully, you can see this table. Mine's covered a little bit by the our faces, but nonetheless, there is data. It's longitudinal. Some of it is cross sectional. Some of it is longitudinal, but it's all based on these large cohorts of patients and looking at patients with different degrees of kidney dysfunction, looking at different endpoints, different time frames, slightly different interventions. But nonetheless, I think it's fair to say to our patient, and more importantly, his family and friends, that there is evidence. I don't think we're ever going to get the double-blind, placebo-controlled, gold standard evidence, but there is reason to believe that indeed eating in a plant-based fashion will obviate the need to meet a nephrologist. And under most circumstances, you don't want to meet a nephrologist. Yes, I think that is the case, that there is evidence, and we'll move on. I wanted to include one quick study, not because it's of particular value or adds much more to the database, but only because it is published in the April CJSON. In other words, it was this month. And here's just another example. Here's looking at that at a large database, and they developed a pro-inflammatory score and an anti-inflammatory score. And not surprising, those folks who were able to eat this bowl, which is full of fruits and plants and vegetables, had a lower rate of developing chronic kidney disease over time. So again, the diet that was the most versus the least concordant with their new score of inflammation had a much lower risk of developing chronic kidney disease. So yes, indeed, there is reason to believe that eating plant-based will keep that creatinine normal. So we can give him that advice. But continuing with the case, he is a 68-year-old male, and as noted, he did present for evaluation of chronic kidney disease. His pertinent past medical history was that of hypertension. It was treated with lisinopril, 10 milligrams daily. He really couldn't give me a very good report on the adequacy of control. He was married. He's retired. He remains very physically active, and actually he leads spinning classes at a local gym 3 times a week. He has 2 dogs, which he takes out pretty much daily, walking on trails and getting his dose of nature. No use of tobacco, alcohol, or recreational drugs. And knowing that he's hypertensive, he wonders, gee whiz, does plant-based eating provide any benefits in terms of hypertension control? And I was wondering if the panel had any thoughts on this.
Dr. Graff, your thoughts, please.
Definitely makes a difference in blood pressure control. I guess one of my questions is how well was his hypertension treated? with his lisinopril at 10 milligrams. So, was he on 10 milligrams, so his blood pressure was still 180 over 95, or was his blood pressure well controlled with that dose? And was he just somebody who didn't want to increase his medication, and so he avoided doing that, and that's how he got himself into trouble? We really don't know that from the history so far.
Dr. Brakey, your thoughts?
Yes, absolutely. The hypertension is largely a disease of inflammation. The endothelium is very sensitive, and when we deprive our bodies of anti-inflammatory foods in the form of healthy plants that are rich in antioxidants, anti-inflammatory phytonutrients, and fiber that stimulates our microbiome to make short-chain fatty acids, we create inflammation, or we set up a place where it's not anti-inflammatory. And then in contrast, and I would amend your question a little bit, not just to say plant-based, but a whole food plant-based diet, because we know that sodium and many components of ultra-processed foods, saturated fats from processed foods, are also pro-inflammatory. So the whole food plant-based diet is not only anti-inflammatory, but it gets rid of the pro-inflammatory parts that inhibit that contraction of the arteries that happens after the valve closes. And it means the heart just has to work harder with stiffened, narrowed arteries. So indeed, high blood pressure is not a disease, it's a condition caused by chicken and cheese and potato chips and French fries, etc. So we can indirectly affect the risk of chronic kidney disease by helping people get a good normal blood pressure with healthy eating.
Oh, thank you. And Dr. Liebman, I'm sorry, I left you out of the last round, but go ahead.
That's all right.
You get an extra 2 minutes.
Yeah, no, the only other thing I would add is a lot of hypertension, especially in chronic kidney disease, especially as it gets more advanced, is volume mediated. These patients are often very volume overloaded. And that's a lot of that is dietary sodium. And, a plant-based diet, particularly if it's a whole food plant-based diet, because you can eat an unhealthy plant-based diet, but the whole food plant-based diet tends to be very, much lower in sodium than a typical American diet. The average sodium the sodium recommendation for hypertension in kidney disease, depending on which guideline you look at, is either 2 or 2.3 grams a day. And the average American probably eats about 3,500 milligrams from the data I've seen. So when you're looking at a volume-mediated disease, lowering the sodium is important. And plants obviously have a lot of potassium, which I believe Dr. Berkowitz is going to get into. But there is good data that potassium is antihypertensive. So I think there are a lot of good reasons why we're going to see why plant-based diets are helpful in hypertension.
Just thinking, if you don't mind me cutting in here, is that, this is a guy who's leading spin classes 3 times a week. Is this somebody who's taking anabolic steroids? Is this somebody who's taking huge amounts of testosterone replacement, trying to make up for kind of like as he's aging? Both of those things are things that can also increase blood pressure and need to be evaluated for.
That's interesting. Yeah. Dr. Berkowitz, back to you. How did the panelists do?
They did pretty well, which is one of the risks of presenting before a crack group of panelists. But certainly hypertension is both a cause and a consequence of kidney disease. And so looking at plant-based eating, there was a meta-analysis of 9 randomized controlled trials that showed that consumption of a vegetarian diet was associated with a lower systolic by about 5 and a lower diastolic by about 2.5 when compared with the diet inclusive of animal proteins. I think the DASH diet is probably something familiar to most of us as lifestyle practitioners. And in a randomized controlled trial of a low sodium variation, it reduced blood pressure in hypertensive patients after 30 days by systolic of 11.5, which is very significant. And the biggest reduction, interestingly enough, was seen in those with the highest baseline blood pressure. And there's a group of studies that was done by Goraya, which we'll be talking about throughout this talk, where they looked at patients with CKD stages 3 and stage 4 in a series of different trials. And the bottom line was by just adding 2 to 4 cups of fruits and vegetables, they were able to achieve a reduction in blood pressure. So yes, there is good evidence, solid evidence that plant-based eating, as Dr. Liebman points out, that's to say whole food plant-based eating, can be effective for control of blood pressure. The mechanisms that were already alluded to include the weight loss that you'd see with a whole food plant-based diet. As Dr. Brakey was pointing out, you can lower your salt intake of sodium. As Dr. Liebman was pointing out, it will increase your dietary potassium intake, favorable changes in the gut microbiome, and even reductions in oxidative stresses. And all these things are going to end up with a lower blood pressure. So yes, I think we can tell our patient that plant-based diets, whole food would work well for his hypertension. Continuing with the case, the exam was asked about weight 218 pounds with a BMI just shy of 30. Blood pressure perhaps not ideally controlled, at least at this visit, at 148/78 with a pulse of 68. The heart exam was remarkable for an S4. Lungs were clear, abdomen, no bruits, and the extremities were without edema. Next slide is the lab review. Creatinine at time of presentation is 2.26. That correlates with an estimated glomerular filtration rate of 28 mils per minute, which is stage G4. His albuminuria was high at 3,846 milligrams of albumin per gram of creatinine, which is an A3 stage. Potassium 5.1, bicarbonate 21. And his 4-variable kidney failure risk equation had a 2-year risk of kidney failure of about just shy of 25% and a 5-year risk of just over 56%. And I didn't think I could give this presentation with Dr. Liebman watching without including our heat map, because this is something that we all have posted in our exam rooms. And just to remind everybody that when we talk about chronic kidney disease staging, we have to consider both what that estimated GFR is and what the degree of albuminuria is. And these things, as you can see from this table, are integrated into a risk. And so as the GFR drops, obviously, the risk, which becomes very high, the lower the GFR, rises. But additionally, as the degree of albuminuria rises, so does the degree of risk. So that's the heat map that, as I say, I think Dr. Liebman and I hold close to our hearts. And in addition to that, currently, it's recommended that not only do you stage the patient's chronic kidney disease in terms of the glomerular filtration and the degree of albuminuria, but it's also nice to give the patient a better, you tell a patient that you have CKD stage 3B. Well, what does that really mean? It's not clear. But when you can actually tell them what their chances of developing kidney failure over a 2- and 5-year time frame is much more impactful to the patient. And so something I try to provide with my patients during all their visits. But moving on to the case, given his high degree of albumin in the urine, we actually decided to do a kidney biopsy. And I won't read the actual features except to say that the findings are supportive of the diagnosis of hypertensive nephrosclerosis. Given all this information to the patient, he's wondering, gee whiz, doc, I heard about this plant-based eating. Is there any evidence to suggest that, wow, I should start plant-based eating now if I want to try to preserve my kidney function and delay worsening and maybe change that risk equation for kidney failure down the line?
So actually, I would be interested in hearing from Dr. Liebman. So Dr. Berkowitz, you used the abbreviation KRE regarding
kidney failure risk equation, KFRE.
KFRE. Okay.
There's more than one model, but I would say that that's the most accessible and popular and what many nephrologists are currently using. I'd be curious to see what Dr. Liebman had to say about that.
Yeah, no, we use it too. As a matter of fact, I just recently discovered there's a little shortcut for it on our EMR, because I used to calculate it, but now I could just push a little button and it calculates it for me. So it's a lot easier. But yeah, it's definitely helpful. And, even without the kidney failure risk equation, you know this gentleman's at high risk to progress with his already low GFR and his albumin of about almost 4 grams. I mean, this is a patient who's at high risk to progress. And I would argue, and Dr. Berkowitz, I certainly know you know this, and I think a lot of people know this too, but just to keep in mind that progression of kidney disease is one thing, but probably this gentleman's biggest issue is his risk for heart disease, and he's probably more likely to die than progress. So,
Mm.
Irrespective, not that, we're going to talk about plant-based diets and kidney disease, but also the question of preventing heart disease comes up here as well. So I know that's not our focus today, but just to keep in the back of your mind that we can maybe kill multiple birds with one, pot, so to speak.
That's a teaser for next month's Grand Rounds case presentation on heart disease.
Okay, excellent. I
Patient
noticed that.
next month does not have kidney failure, so
Yet.
yeah. Well, now he won't, but you'll find out next month.
But I did notice that he was predicted to have a 56% chance of renal failure in 5 years. It looked like on that. That's, yeah, that's got to be pretty scary to the patient.
Yeah, and that's a chance of like dialysis dependent renal, not just progression, but being on dialysis or need a transplant.
Right, that's what I figured. Interesting.
What a
Dr.
huge change from his quality of life now, right? He's leading a couple of, spin classes every week. And the idea that in a couple of years he's going to end up being on dialysis. That's a massive lifestyle change for him if he doesn't do something to stop this progression.
Dr. Breaky, any comments on that?
Yeah, I think this is a critical point. Most people don't progress all the way. They end up dying of heart disease. The same risk factors that create chronic kidney disease, systemic inflammation, animal protein, saturated fat, create the environment where the arteries clog and can increase risk of both strokes and heart attacks. So yeah, the number of people who have that risk, but that, within 5 years, if he dies of heart disease, he's not in the 56%. So critical point.
Right.
And the good news is that the same diet, it's not a different diet that helps for heart disease or hypertension or insulin resistance or chronic kidney disease or Alzheimer's prevention. It's the same whole food plant-based diet that helps for all of them. So good news.
Right. All right.
All right. Well, so just to show you another table, this one is a summary of studies using plant-based diets with established chronic kidney disease. And again, some of them are just longitudinal studies, but the last three are by this physician Goraya, who we already saw one report with terms of hypertension, who actually is performing randomized trials with control arms, and the study arm getting these 4 servings of fruits and vegetables. And so they are actually prospective and randomized and in patients with both CKD stage 3 and 4. But again, yes, there's reasons to beyond the heart disease, which is probably the best reason, but there's also reasons in terms of preserving kidney function that we can go ahead and recommend a plant-based diet. And that's what we did.
Can I just interrupt for 1 second? I just wanted to add that if on that table, the Goraya studies, I think, are 1, 3, and 5 years. I don't know if they've published it yet, but at the nephrology meeting last year, they actually presented their 10-year data, and they did have data that it led to decreased incidence of dialysis. So their data extends now to 10 years.
Wow. And just to be clear, the intervention, Dr. Berkowitz, one more time, the Goraya intervention.
3 to 4 servings of fruits and vegetables.
Right. So it's not putting them on a whole food plant-based diet. It's just increasing fruits and vegetables.
Right. And we're going to talk more a little bit about these studies.
Okay, great. Thank you.
Yeah. So the patient reviewed the data that we just presented and said, gee whiz, this is compelling, and I guess I should be doing it. But well, is there any biology to support, that this would work? I mean, why would it work? And so that's the question. Are there any mechanisms that the panel can suggest to us as to why these whole food plant-based diets, as we just heard, over a 10-year time frame, can delay progression and prevent dialysis?
Great question. So let's start with Dr. Liebman. What are your thoughts about why?
Yeah, I mean, there are several. The one nephrology specific one that comes to mind for me is our patients with kidney disease, especially advanced kidney disease, often get what's called a metabolic acidosis. And I think that's going to come up a little later, so I won't say too much about that. But when your kidney function drops off, you can't clear your body's acid, and that has deleterious consequences, one of which is to actually worsen kidney function. So it's a bit of a negative feedback loop. And I think we'll see a bit later that I don't want to steal your thunder, but I know that there's certainly, that's one mechanism. So I'll take my one mechanism and bow out and
Okay.
my co-panelists.
Dr. Graff.
Yeah, so if you're eating a lot of greens, you're increasing blood flow to the kidneys, which should help also with being able to filtrate better. So if there's any kind of blockages that are going on, even with the small arteries, if you're dilating even a little bit, you're going to be able to increase function with that just from the increased nitric oxide from the increased greens that you're eating. So I'll pass it on to Bob Rickey. You'll probably have like 6 things to add to this because he is like the guru for all of the mechanisms. So passing to Bob.
Dr. Berkey, no pressure.
Actually, I only have 5. But probably one of the most, well, let's look at overarching first, of course. Hopefully, plant-based diet decreases the risk for hypertension and insulin resistance, which are overall risk factors for chronic kidney disease. But again, going back to kidney specific, one of the main ones is called hyperfiltration. When you give a person animal protein, their kidneys ramp up filtration rate up to 35 to 45% within hours. They end up kind of revving up to manage this more pro-inflammatory protein. And we know it's related to the inflammation because insulin can block that effect of hyperfiltration. It also, if you give a person the same amount of protein in the form of tofu or bean curd, no ramp up in filtration. Now, again, this is an evolutionary adaptive mechanism for short terms of animal protein for the kidneys to be able to process that pro-inflammatory source of protein. But when it's on 24/7, 365, like most Americans, eating this animal protein anywhere from 1 to 3 times a day, the kidneys eventually give out. The other is the sulfuric acid, the sodium, the saturated fat is pro-inflammatory, and the lack of fiber. But we can get into those more if people want to during the Q&A.
Wow.
Yep.
Good show, guys. All right, back to Dr. Berkowitz.
Yeah, so I'll go quickly because I do want to leverage Dr. Liebman's expertise for plenty of questions at the end if they arrive. So there are several mechanisms. One of them is fiber. And we know that fiber will shift the gut microbiome from a proteolytic to a saccharolytic composition. And the proteolytic microbiome leads to the production of uremic toxins, which I will not try to pronounce, and allowing increased absorption across a leaky gut wall. These toxins are linked to the progression of chronic kidney disease through inflammation, insulin resistance, and of course, there's good old cardiovascular disease. On the other hand, a saccharolytic microbiome results in short-chain fatty acid production, which can improve gut integrity. So fiber is important. I also say that it prevents constipation, which is important and will be discussed a little bit later. I included this side because, as I'll tell at the very end, I'm very proud of the American Society of Nephrology because it was just announced in the latest issue of CJASN, the Journal of the American Society of Nephrology. Got it in my mailbox today that they're starting an entire series on lifestyle medicine and kidney health. And this one was published in advance online. And you can see that the gut microbiome and the kidneys talk to each other. It's bidirectional. So, once you start developing kidney dysfunction and uremic toxins start to build up, that's going to impact the gut in unfavorable ways, partly by altering the pH of the gut. And as you get a dysregulated gut microbiome, as just discussed, it's going to create maleffects on the kidneys. So fiber is certainly important for the gut microbiome, and the gut microbiome is important for the kidneys. So that's one potential mechanism. Dr. Liebman was being polite because he could have scooped me on all of them, I know, but he chose to hold back and just mention acidosis. And as Dr. Berkowitz mentioned to us, Animal proteins tend to increase dietary acid load due to the sulfur-containing amino acids, and therefore, a high animal protein diet is going to be an acid diet. On the other hand, plant foods are actually accompanied by alkali precursors, and so that's going to be an alkaline diet. And high dietary acid loads increase things like TGF beta and fibronectin and endothelin and a bunch of other mediators of kidney inflammation and progressive loss of GFR in animal models and evidence even in humans. This is just a depiction of metabolic acidosis. As Dr. Liebman pointed out, as you lose filtration, as kidney function declines, you have an inability to handle the dietary acid load. And when you can't handle the dietary acid load, it leads to ammonium accumulation in tubules, which leads to complement activation. It can lead to increased upregulation of angiotensin II and endothelin 1. And all these things cause interstitial fibrosis within the kidney and loss of filtration. And it's an unfortunate positive feedback loop. I know I've heard Dr. Brakey many, many times, and I know he has a version of this slide in his talk, but it's an important slide just showing that if you're wanted to decrease the acid load on the failing kidneys, you're much better off eating a base-producing diet, and that just happens to be a whole food plant-based diet. And then lastly, I couldn't, Dr. Liebman did scoop me, may not have meant to, but he did, because he gave us the 10-year outcome. But this is these Goriah studies, these studies that I've been mentioning, these randomized studies using 4 servings of fruits and vegetables. And this one's after 5 years, but we just heard the 10-year studies. And you can see that, yes, you had an improvement in bicarbonate, but you had these side effects, so to speak. One of the side effects was you lowered your blood pressure. Another side effect was you lowered your LDL, and that occurred with the fruits and vegetable diet. Interestingly, you did not see the same magnitude when you just gave them sodium bicarbonate tablets, right? And of course, with usual care, things were not as good. So these people were losing filtration close to 20 milliliters per minute, which is terrible. If you just gave them the sodium bicarbonate tablets, it improved. But if you chose to include just fruits and vegetables as a way of treating that acid load, they got the best improvement in kidney preservation. They only lost kidney function at about 10 mLs per minute. So these were an impressive set of studies and really suggest the benefits. And let's quickly do another poll question. I'm going to hurry a little bit so we have plenty of time for questions.
Okay, let's see the results, please. Okay. Dr. Berkowitz, I'll let you comment on this. Well, actually,
Well,
go ahead.
Yeah. It looks like I can stop talking. Just about everybody got it right.
Okay.
Maybe that's some kind of hint. So I will try to speed up a little bit.
All right.
So in terms of
okay, do we don't want to hear from everybody else or not?
Yeah. Oh, okay.
Yeah. Let's hear from Dr. Liebman. We'll just quickly. What do you think?
Yeah, well, quickly, the only thing I'll say is, there's a little bit of a dichotomy in protein intake in nephrologists in kidney disease. Some people swear by low protein diets. Some people do worry a little bit about nutritional issues if patients get on dialysis. But I would argue that your poll is correct, and there's no evidence that increased protein helps. So I think it's either decreased protein, certainly decreased animal protein for the reasons that Dr. Brakey mentioned, but no evidence to my knowledge that increased protein does the trick.
Dr. Graff, you're unmuted, so you get to go next.
Yeah, so I don't have anything to comment about the poll, but according, looking at that last graph that you showed, and like that's the kind of results you got with 3 or 4 servings of fruits and vegetables a day. Wouldn't we just love to know what the data would look like with a completely whole food plant-based diet, right? Like if you can get that much power, that much improvement out of 3 to 4 servings of fruits and vegetables a day, how much power would you get out of having a completely plant-based diet? So I wish we had that data, but.
Yeah, no, that's a great point. Dr. Brakey, what are your thoughts?
So people, of course, nobody talked about increasing animal protein, which is absolutely correct. two main reasons for that are that we don't eat protein, we eat food in packages. And animal proteins come with saturated fat, lack of fiber, pro-inflammatory compounds like heme iron and stimulate TMAO. Plant proteins come with fiber, phytonutrients, antioxidants. So it comes with other things that are either harmful or not. The other main one that people don't recognize is that protein breaks down into different amino acids because it takes a different component of, in particular, methionine to make an animal muscle than it does to make a stalk of broccoli. And plant protein have plenty of methionine, one of the two sulfur-containing amino acids. But once you get above about 85 milligrams per 100 calories, it becomes a pro-oxidant. It's pro-inflammatory. It increases insulin resistance and systemic inflammation, in particular on the kidneys. This is part of the mechanism for hyperfiltration, for kidney nephrotoxicity from animal proteins in particular that are high in both methionine and branched chain amino acids, leucine, isoleucine, and valine. Paul?
But Dr. Brakey, aren't complete proteins important?
He's baiting me. Thank you, Paul. Of course, we were taught back in the 70s by Francis Moore Lepay that plant proteins are incomplete, that you need to combine rice and beans to get complete. We now know that's completely false. All foods have all 20 amino acids, except gelatin is lacking tryptophan. But all proteins have all of the 8 essential amino acids in adequate amounts. So all proteins are, quote, complete proteins in the sense that they give us the adequate amounts we need. And what's most important is that you don't get too much of the ones like methionine and leucine that are actually pro-inflammatory. So thank you, Paul.
Yeah,
great answer. There was a protest from the illustrious Dr. Scheuer in the chat who thought that it was a trick question because does it matter if the patient is on dialysis or not as far as the protein requirement? Dr. Berkowitz, can you comment on that?
Yes, probably. I can tell you that, as Dr. Liebman said, there is thoughts in the nephrology community that prior to transplant, perhaps limiting protein is important. There's going to be a slide on that in a minute. But yeah, once they get on dialysis, I think we liberalize the protein intake. But still no need for complete proteins.
Got it. All right, thank you. All right, proceed, please.
Yes, sir. So high protein diets, as was just mentioned, have been linked to worsening of chronic kidney disease, especially animal proteins. And what I wanted to show was this next slide looking at plant-based diets. And I think this is from Dr. Kalantar, and this is, I believe, funded. Now, Dr. Liebman, you may know more about whether it's actually gotten its funding, but he was very interested in looking at the Plato diet, which is a plant-dominant, low-protein diet, which is going to obviously test both concepts as whether low protein in and of itself is helpful, but particularly whether sticking to the plant world as opposed to the animal protein is going to be effective. And so this will be very interesting and very important study, and hopefully it did get funded, and hopefully we'll get results one of these days. So that's the only thing I wanted to say about protein. And I just wanted to move along a little bit because we have at least 2 more important topics to discuss. Case continues. Patient is confused by the advice that he's been given regarding plant-based diets and CKD treatment. He was reading the posters plastering the waiting room and exam room, warning against fruits, vegetable, legumes, whole grain products due to potassium and phosphate concerns.
Oh, yeah.
Isn't that true? Don't we have to worry about these things? And I'm going to turn it over to the panel. Sounds like everything we've been talking about may actually be dangerous for CKD patients. Should we be concerned?
I'm going to let Dr. Brakey start. Oh, go ahead, Dr. Brakey. I want you to start on that because you've got the biggest grin here.
No, I was just going to say, as
Okay.
Paul, I'm sure you know, this is one of the biggest things we have to fight in clinic. And what I tell my patients is, Google will tell you a lot of things, but they're not all right. Yeah, if people have high phosphorus levels or they have high potassium levels, you probably don't want to be eating tons of high phosphorus foods. But again, even there's nuances because plant-based phosphorus is not the same as animal-based phosphorus, which is not the same as inorganic phosphorus that you get in processed and prepared foods. But for the vast majority of patients, this is something they really don't have to worry about too much. So it's just something we fight all the time. And even people in early stage chronic kidney disease will come in, tell me they're restricting their potassium and restricting their phosphorus, and I'll try to tell them they don't need to do that. So that's my 2 cents.
Got it. Dr. Brakey.
Yes, we know we've learned back in physiology that the kidneys are largely responsible for both phosphorus and potassium balance. Interesting, when you have the acidic environment, when they're busy trying to excrete that extra hydrogen ion from a high animal protein diet, it makes them less able to manage potassium. It gets into, again, one of those negative feedback loops. So a plant-based diet with potassium is more easily managed. We also can measure potassium and phosphorus levels, watch for this. And I know Paul's going to come to some additional components of this, of how we have meds if needed. We don't have to restrict super healthy foods like fruits and vegetables, again, in the vast majority of cases. So thank you. Common myths that we are helping here to dispel.
Dr. Graff.
I have a patient who's in this position. I just do a standing order for electrolytes and kidney function. And I'm like, just go as often as you want to check this, like every couple of days when they first change over to a plant-based diet. And what I haven't had a single person get into trouble with it yet. And all they see is that the electrolytes are fine and their kidney function improves. So basically, that concern that patients have about wanting to try it because like they've been told that it's dangerous, if they're able to go and get their labs checked, that really just kind of relieves that angst that they have. The caveat to that is that I encourage them to always go to the hospital to have their labs drawn and not do it an outpost where the potassium might sit or the blood might sit for 4 hours before it gets into the lab. And then you get hemolysis and then your potassium comes back high and they get completely freaked out. So, but that, I have not ended up having a problem with a single patient with that being an issue. And all you see is either the kidney function stays stable or it improves where their electrolytes stay fine. And thanks to Dr. Liebman for the work that he's done looking at studies to making sure that that is actually safe to do. So, Dr. Liebman, do you want to talk a little bit about the study that you did up at URMC?
Just very briefly, because I don't want to take up Paul's time, but we did very short duration study of 2 weeks where they went through the RLMI's Jumpstart program, folks with moderate kidney disease, and it turns out really there was no difference in their potassium or phosphorus level. And these folks, I don't have the data with me, but they really changed their diet. Their potassium went up by about 40%, but their serum potassium didn't change. Now, granted, these were moderate kidney disease, so I don't want to extrapolate to everybody, but certainly there's at least a hint that we can certainly breathe easy in that regard.
Right. Thank you for that. All right, Dr. Berkowitz.
All right. Well, again, I've been preempted, but I will continue nonetheless. So potassium, in terms of potassium, there's been little to no association found between potassium levels and dietary potassium intake, as Dr. Liebman just confirmed for us. Plant-based foods have fiber, which we discussed earlier. The fiber is important because it prevents constipation. Why is that important? Because it turns out as you lose GFR, the colon starts to increase its secretion of potassium, and it is responsible for increasing amounts of potassium disposal. So constipation is associated with worsening potassium. It has natural alkali, which we discussed in those Garaya studies, which also help with potassium disposal, and it results in improved insulin sensitivity. And insulin is what transfers potassium into cells after ingestion during a diet. So all these things are going to improve potassium disposal, even if you're increasing quantity with your plant-based diet. As a tip, I do tell my patients, especially with more advanced chronic kidney disease, that they should avoid juices, sauces, dried fruit, and potassium substitutes, especially some of the salt substitutes that people don't realize are potassium chloride. And as Dr. Liebman points out, foods that are unusually high in potassium should probably be avoided. This was just a table put together. You can see the top two of those Garia studies. If you look at the column labeled hyperkalemia, you can see that despite people being put on plant-based or more plant-forward diets, let's say, that there was no hyperkalemia seen except in one single patient. And even in dialysis population below the line, with the observational studies, it's still there was no association between dietary intake and potassium. It's not to say it doesn't have any role. Here's just another study. This is done purely in hemodialysis patients. You'd think they'd be the most sensitive to dietary potassium intake and blood levels, and yet the association was not strong, that's for sure. So I think that potassium is something, as Dr. Graff points out, does need to be monitored, but in no way does plant-based eating and chronic kidney disease represent a risk. And only because this is lifestyle medicine talk, I did want to at least introduce another pillar. I couldn't go without at least a second pillar. And this was just interesting, is that, gee whiz, does exercise benefit hyperkalemia management? And the idea is that muscle is a very important reservoir for body potassium. So the more muscle you develop, the greater your reservoir of potassium. And furthermore, if you exercise, you improve insulin sensitivity. And again, insulin is an important mechanism for shifting dietary potassium into cells and buffering it. So I just thought that was interesting, and I couldn't help myself. But what I also wanted to bring forward, and I'm curious to see Dr. Liebman's experience with this, whether he can give us his experience with this, is they now have potassium binders. These are medications taken by mouth, which have the ability to actually bind potassium in gut and actually remove it from the body, and have been found to be effective in control of hyperkalemia. One of them is called Partiromer. The other one is sodium zirconium cyclosilicate. And they're FDA approved, and so we have real studies that demonstrate their ability to lower potassium. There's a lot of interest in combining these medications, this thing with RAS inhibitors, but I also think there ought to be an interest in combining these medications with plant-based eating. If you do have a patient seems to be running high, is on a whole food plant-based diet, I think taking one of these medications to control potassium is a far better choice than condemning him to the standard American diet, especially when, as we just shown, the relationship between dietary potassium and blood levels are not that tight to begin with. So that's one thing. I would like to hear Dr. Liebman on that in a second. In terms of phosphate, it is the case that elevated phosphate levels are an independent risk factor for mortality in a group of CKD patients. But as Dr. Liebman started to allude to, and respectful of time, didn't go in too much detail, and again, he can speak further to this, but the old advice was to kind of just measure the amount of phosphate in the food and then declare it either high level of phosphate or low level of phosphate. And, one food you couldn't eat and the other food you could eat. But it turns out that phosphate in plant-based foods are bound to phytates. And we don't have the ability to cleave the phosphate from the phytates. So only 10 to 30% of plant-based phosphate is absorbed. On the other hand, if you look at the phosphate in animal products, there's about 40 to 60% of that is absorbable. And if you look at the phosphate that come in as additives, like in colas and things like that, it's very easily absorbable. And I once heard the idea, it's the rules of thirds. Plant-based phosphate is 1/3 absorbed, animal-based phosphate is 2/3 absorbed, and the phosphate additives are basically 100% absorbed. So I think it's these charts that Dr. Liebman and I have to fight against are really not accurate, because they fail to take into this idea that plant-based phosphate is poorly absorbed. So that's actually my last slide. And I just wanted to make the point that, and again, you can very proud of my C. Jason. I just got it in the mail, opened on the mailbox today, and they were announcing the the Lifestyle Medicine and Kidney Health series. I believe it was 18 articles that are going to be coming out over the next months, all dedicated to aspects of lifestyle medicine and chronic kidney disease patients. So, yeah, there you go. So I did want to hear Dr. Liebman's experience with potassium phosphate and possible use of binders.
Yeah, I mean,
Fantastic. I'm going to just interrupt for once. Thank you so much, Dr. Berkowitz. That was a wonderful presentation. Thank you very much. I'm actually going to ask you to stop sharing so we can have every
Did I
people.
do it? Yeah.
Yeah, you did a great job. That's perfect. Thank you. Okay, Dr. Liebman.
no, I was just going to say, like you, Paul, we use the binders pretty religiously. I mean, there's good, as you show, there's good evidence for plant-based diets. I mean, and again, we know there is good, some medications certainly do have their roles. There's very good evidence for our RAS inhibitors. So, we do use them pretty liberally to keep patients on these medications and to, if they do have problems with dietary potassium, which, really isn't as huge an issue as we think it is. But yeah, and I typically prefer patiromer over Lokelma just because of the sodium issue. We do, as you know, we do run into volume issues with our patients. So I'm not a huge fan of Lokelma, but sometimes insurance companies dictate that for us. And yeah, the phosphorus thing, I mean, my biggest thing for patients is really to tell them to avoid the highly processed foods. Like you said, that's the big bear when it comes to phosphorus absorption. So, I tell them not to worry and talk about, phytate and phytase. And I don't know how many people care about that, but I just tell them that it's not just what you get in the food, it's what gets absorbed. So agree 100%.
Any
If I
comments
could
from go ahead.
to ask our nephrologists about how they relate to dietitians who may have specialty in renal dietetics, still kind of telling people, hey, don't eat your fruits and vegetables because of these issues. Are you finding they're coming up to speed too, or are we making headway there?
Yeah, I mean, I could just say my experience is our dietitians are pretty well versed on this at this point. So I don't know about you, Paul, I haven't come across it in a while, to be honest with you.
Yeah, I'm kind of spoiled where I'm at, and Bob knows this because we have a whole cadre of dietitians who are lifestyle medicine boarded and certified, and so I'm lucky in that regard. But I do think a lot of it still prevails, and I will tell you that I'm embarrassed about some of the posters in my waiting room and in my exam rooms, and I will tell you that the dialysis companies are also, I think, coming on board, because they sponsor the dietitians in our dialysis unit. So,
Panelists, do they have any comments?
I want to know, Dr. Berkowitz, if your patient adopted a plant-based diet, what happened?
so he did adopt a plant-based diet, and I will tell you that this is not a new case, quote unquote. In fact, I had to submit this case for my board certification in lifestyle medicine, which was pre-pandemic. So I met him well in advance. He has had some worsening of his kidney function. He's not on dialysis. He is looking into a preemptive transplant, but it's an N of 1 in some sense. And for a while, I did have him on potassium binder, but it doesn't seem to need it that much. So,
Well, seeing as he had a 50-some% chance of being on dialysis by now, since the pandemic was over 5 years ago, you're doing great, right? So he's
yeah,
doing better
well,
than his odds.
yeah, thank you.
There were some questions in the chat that I wanted to. So here's a question. So if they want to incorporate a salt, would a salicornia green salt be a safe alternative? Why or why not? Does anybody know the answer to that question? I'm not even sure what that is, salicornia.
I don't know either, but I guess my answer would be a lot of people come and ask about sea salt and this salt, but if it's NaCl, it's still salt. So no matter
Right.
what it is, it's salt. So
Yeah.
I would just be careful. And the other thing, there is some data on salt substitutes, and they do contain inorganic potassium that might be a little bit better absorbed. So that might be something to be a little careful of in your kidney disease patients. So I would just throw that out there too.
Very good. Okay. Somebody asks, is MSG okay for patients with CKD? So monosodium glutamate for umami flavor. Dr. Berkowitz, you want to take that one?
I don't know of any data on that. So
Okay. Any of our other panelists have any thoughts on that one? There is sodium in there, obviously.
I found some mouse data on that, and it looked like it's a little better than sodium chloride, but still not ideal.
Okay. All right.
Yeah.
There you go. From the audience. Thank you so much for that.
Thanks.
There's a question in the chat that I kind of answered, just typing in the chat, that was, what do I tell my son who is 29 years old and eats a paleo diet? And I was like,
Uh-huh.
well, if the diet is mostly vegetable based with a little meat, not so bad. But if it's mostly meat based with a few vegetables, then it's a problem, right? So, anybody else have any comments about kind of how bad that can be?
Yeah, paleo and the carnivore diet. Dr. Brakey, you wanna do a rant on that one?
Yeah, I won't go too long. If you see it came from a misconception that the paleo period, which is really only the last 20% of human evolution, when our ancestors moved north and sometimes required animal just to survive and make it to the ripe old average age of 24 and procreate, is somehow the normal human diet. But most of human evolution was in Africa, where plants made up 98+%. And our physiology, our anatomy was very well developed there. And you can see that the difference in the length of the alimentary canal. Pertinent to this, carnivores have kidneys 3 times the size of ours per body weight than humans do, because they're designed to handle that much more protein and saturated fat. So everything about our structure, from our jaw to our alimentary canal to the villus structure, says we are plant eaters. And so this is a misinformed misconception about human nutrition. And unfortunately, as Paul Berkowitz says, people on the keto, the paleo, the other diet, they fit in a skinnier casket.
True carnivorous animals don't develop atherosclerosis when they eat meat. We
That's
do.
right. That's right.
So we know this is not what we're meant to eat. So, and if you look back at a true paleo diet, they were eating at least 70 grams of fiber a day. So 3 times more than we do in the standard American diet. They were eating a lot of vegetables with some meat.
Yeah.
And they also make their own vitamin C too, right? So
I don't know about that.
yeah. We need vitamin C because we need vitamin C because our bodies got used to eating lots of vitamin C in the
That's
form
right.
of the plants.
Yes,
Right.
yes. They don't make their own, though. Humans and guinea pigs need to take vitamin C.
No, but carnivores make their own. Isn't that correct?
Oh, right. Yes, sorry. Yes, you're right. Yeah, thank you.
Okay. Yeah.
Yeah.
And
Thank you.
I was just going to say, there's a question in the chat about what data supports a whole food plant-based diet for PKD, and if that means polycystic kidney disease. I just wanted to answer that to my knowledge, I don't know if there's anything specific to polycystic kidney disease, but I would argue that, blood pressure control and all the same things that we've been talking about are important. So although I don't think there's any, and Paul, correct me if you know better, I don't think there's any evidence specifically on PKD.
I think so I think there's been some interest in keto diets and PKD. And I would call the stuff preclinical. I think there was one feasibility study, very short, So yep.
So somebody sent a question directly to, go ahead.
There's also a question about high oxalate whole food plant-based diet of concern in CKD. I don't know, in my mind, it's mainly a risk for a fine-tuning risk for kidney stones. Some people, animal protein is the biggest risk for kidney stones. You can decrease risk by 250% just by switching from animal to plant protein. If people still have a propensity for stone formation, they do have to watch high oxalate foods like spinach, rhubarb, and Swiss chard. But kale, broccoli, and others are relatively lower amounts and okay. And even those other foods are okay. But I don't know if our nephrologists have any info about oxalates in chronic kidney disease. I don't think it's an issue.
If you cook the foods that have high oxalates, you get rid of most of the oxalates. So just cook your spinach.
Yeah.
Okay.
If you're worried about kidney stones, you're better off cutting your sodium than you are your oxalate.
And drinking.
Yeah.
Okay. Yeah, I don't know specifically about oxalate and kidney disease. I'll be honest with you, in my 20-something years counseling patients, I've never really focused on oxalate other than in the kidney stone population. So I'm not even, and maybe I'm just out of touch. Paul, maybe you know better, but I don't even know any epidemiologic data with oxalate and kidney. I just don't know.
Right.
I think that's right.
Yeah, somebody sent me a personal, I don't think they meant to send it me directly, but they did. Are herbs and spices okay as salt substitutes? And yes, they're the best, right? If you,
2 thumbs up.
yeah, absolutely.
Yeah, Ted, if I could just make one more comment,
Sure,
that
please
there's
do.
a
Yeah.
common question about, is chronic kidney disease reversible? And obviously, just like emphysema, it reaches a point where it's not. You lose nephrons, they'll never grow back. But there's also a thing of nephron strain, and related to this inflammation, hyperfiltration, acid, and other. And I know Dr. Liebman and Dr. Berkowitz have seen this case I presented before, but I've got several patients now who have had chronic kidney disease, and been able to reverse that. This was a patient who had declining kidney function. This is her eGFR over an 8-year period, going down from basically low 50s down to 36. I finally inspired her to adopt a whole food plant-based diet. That we switched EMR to Epic in 2020. She noted a dramatic improvement and then fell off the wagon, multiple life stresses. But you can see then get once again towards 2023, got really back on it, and recovered back to her baseline in the 50s. I know, Scott, you commented before, like a few years ago, you wouldn't have think this was possible. I was somehow making it up. But are you all seeing this now too? Because this is what we're seeing, is that people who have the strain phase of it can recover, just like we can see with acute kidney injury. And again, I've seen several cases now. We have to be careful, because you don't want to have people think that, oh, I can eat, drink, and be merry till it gets down to 20 and then just reverse it. No, you could be getting yourself in trouble. But don't give up on these people. Don't think that dialysis is necessarily in their future. Another study showed type 1 diabetics dropping dramatically over the prior 24 months. And then all of them, 8 of them, small study, leveled out on a whole food plant-based diet. This is not an inevitable consequence. And I think that's our main message today. Lifestyle medicine with exercise, good quality sleep, and especially whole food plant-based eating has good hope to arrest, and in some cases even reverse, chronic kidney disease, just like diabetes, heart disease, hypertension, obesity. We got to get this message out there. Thank you.
Yeah, thanks for that, Dr. Bakey. On that note, there's a lot we could keep talking about. There's a lot of passion here, and I know there was even a question in um, uh, the chat about why medical groups are still recommending low carb diets. But that's probably take a few hours to have that conversation. So I think we're going to officially adjourn now. I just want to thank everybody for attending. We're a nonprofit. We run entirely on donations. I'm a full-time volunteer, and I make my living as a radiologist. Thank you, Dr. Berkowitz. Thank you for doing the heavy lifting on this by presenting this case, and Dr. Liebman for being our guest panelist. Dr. Graff for always being there as our case wrangler, and filling in for Dr. Sunderman when she can't be around. And Dr. Brakey, of course, thank you as well. And thank you all for attending tonight.